in a pediatric ICU, and mostly we have a model of it's the PICU doctors to outside emergency departments for sick kids, a telehealth program like that. Maria, I'm also part of the RAPM group as well on the telemedicine um, portion of that group. And so just super excited and interested to, there's amazing expertise, Kate, that you have on this, excluding me, but like on this call. So congratulations. I'm excited to learn a lot. I also have a couple of conflicts, but I plan on joining my 1 o'clock a little bit late, but I'll have to jump off early on this.
Okay, no worries. Thank you so much, Jim. Rachel Alter.
Hi, yeah, I think I'll have to excuse myself from the expertise side of the telehealth right now, but I'm excited to join this group. I am staff support for the Pediatric Emergency Care Council of the National Association of State EMS Officials. And my second hat is, or second, third, and fourth hat maybe, are co-leading the state partnership and pre-hospital domains of the EIIC, as well as co-leading the pre-hospital pediatric readiness project that the EIIC is leading. So I'm just really excited to learn from all of you and help move this project forward. So thanks for having me.
Great, thanks, Rachel. And John, you've already said a quick hello. Is there anything else you'd like to say?
No, I don't think so. Just happy to be here and let me know how I can help.
I'm super sorry, Rachel. Has this gone out to all of the state coordinators? I apologize about the call. The state partnership.
Yes, I sent an email to all of the program managers and the program directors for the EMSC state partnership program.
Thank you. All right.
Yeah, and we also held 2 separate office hour sessions answering questions. So we had about 10 to 12 states, I think, that joined in on those calls. So there has been some interest.
Thanks. When John listed,
sure.
I don't think he said California. I got pissed and emailed our people. So they better say they knew about it now that I know.
Actually, Heidi did jump on the call shortly. She never asked any questions, but she was on briefly on one of the calls. Yeah,
I emailed Heidi. Yep. So,
she's good.
I'm going to pull your name out, Rachel. Thank you.
Sure thing.
And, Rachel, if I can, since Jim brought that up, I previously lived in Martin, Alaska, and I was just aware because, that most of the folks in the section that houses EMSC have been redeployed for COVID. And so I just texted one of the docs who I knew was on the board, and I said, do you know about this? And he said, no. So I sent it to him, or, on their advisory committee, but that might be a thought, especially for the programs that are housed in a state health department. They might be so swamped right now that they can't even parse this out. So if there's a way that, if like there's secondary contacts who don't have an at state whatever email address, it might have a little bit more wavelength bandwidth for this at this moment. That might get more interest.
Great. Well, we did send it out, and they should have received it multiple times through their HRSA project officers as well. But we have one last person, Rachel Abbey. Can you introduce yourself really briefly? And then I know John's going to be sharing his screen afterwards.
Sure. Thank you so much. So my name is Rachel Abbey. I'm with the HHS Office of the National Coordinator for Health Information Technology. Our primary mission is to ensure that patients and providers have access to their data when and where they need it. Many of you may be familiar with, we certify electronic health records specific to core capabilities and functions and things like that. We also do a lot of work with health information exchanges, particularly in states, and helping them to coordinate care across the healthcare continuum, including emergency care. And then lastly, we also, we work a lot with Medicaid and public health departments to help them to leverage existing health IT infrastructure in their states. And so I think that this is specific to your work in the sense to make sure that telehealth is part of that, and that you're leveraging all of the pertinent resources that are available to you all in your states and communities. I did want to say that we have done a little bit around pediatric care. So we do have a specific spot on our health.gov website that talks about health IT for pediatric care and practice settings. And as part of the 21st Century Cures Act, we have been requested to develop a voluntary certification process for EHRs related to pediatric healthcare settings. So thank you.
Fantastic. Thanks so much for sharing that. And then Michael McNeely, I see you jumped on. Do you mind introducing yourself briefly?
Hi, Mike McNeely, Director of the Office for Advancement of Telehealth. Sorry, I'm jumping from meeting to meeting today.
No problem. We appreciate you being here. I know everyone that's part of this is busy, so we're just grateful for your time. So,
No worries.
John, I think you're going to share your screen. Do you want to walk us through the process?
Yes, so we have kind of an Excel sheet to kind of help guide us. And again, we mentioned doing the round robin setup. So Rachel, Abby, we were going to start with you first, kind of as we go through the categories, to give everyone kind of a chance to discuss what they think, you know, a topic is for technology requirements, or whatever it is we're talking about. So we'll just go down the list, and if we end with one specific person, say Mike Gonzalez, the next person, Dr. Higa, will start up the next section. So yeah.
So if you just remember the person who's before you, and I think T and Tam both had to drop off, John. So we'll have a quicker, group. We have a number of areas that we'd like to try to cover today, or at least brainstorm about. And as we speak, John will be typing into the Excel sheet. So you'll be able to see comments that have already been shared as we go. And it would be nice if we can spend maybe about 30 minutes per person, or 30 minutes. We would get through everyone. 30 seconds per person, and then we'll just kind of move on to the next, and not trying to be, overly structured, but wanting to make sure that everybody has a little bit of time to share their important perspectives. So the areas that we're really going to be talking about today are the types of emergency care services that might be, accessed through telehealth. So what do those look like? Then we'll be jumping into maybe some regulatory requirements or changes that might exist, both in terms of licensing, but also security issues and the like. Beginning to think about some technology requirements, and we may not get beyond that. If we do, great. Then beginning to think about some training opportunities, finally some reimbursement strategies and challenges. So really just all different types of telehealth. And again, the specific focus here is on emergency care for children, specifically children with behavioral health emergencies and children and youth with special health care needs. But really beginning to think about what this looks like from the perspective of the family, and also from the perspective of a caregiver or other healthcare provider who might be actually providing these services. So beginning to just think about what types of emergency care services might be available through telehealth. So I guess Rachel, Abby, if we're okay starting with you, and then we'll just kind of run through the list and see. So what initially
Sure.
in mind for you?
Are you talking like settings like EMS or like
Sure,
community paramedicine? Is
Sure.
that
Certainly could be settings, or it could also be, what actual service could be provided, like an assessment or monitoring, things like that. So.
Oh, I see. Okay. Well, yeah, I think definitely there needs to be some sort of triage and assessment piece that would need to be put in place.
Okay, perfect. And if there's anything else you want to add as we go, and we'll just kind of run the list and see how, everybody has a chance to talk. So Rachel, Alter, you're next. So is there anything else that you would add to that besides triage and assessment?
Yes, I would love to see, I don't know if it's necessarily suicide prevention, but something along the lines of suicide, whether it be assessment or post follow-up for somebody who might have potentially tried.
So maybe suicide screening, is that what you're?
Yes, that's the right word. Thank you.
Perfect. Yeah, that's great. Thanks. And then Sabra?
I'd say consultation services to determine if a patient is appropriate for a higher level of care.
Fabulous. Okay, and then, oh, and Kate had to drop off. So Mike?
Muted as always, perennial problem.
You're fine.
Sorry. So I mean, we tend to think of it from the EMS perspective as more acute problems, right? So unscheduled care, acute problems. So the first thing that came to mind was sort of crisis intervention, which is related a little bit to the triage, but sort of we look at it in terms of trying to solve, is it possible to solve this crisis in place, right? Treat it in the home or triage it out to somebody else. But either way, some of these the behavioral solutions that we've dealt with are often super focused, are the most amenable to telehealth in my experience.
Perfect. Thanks. Christina?
Okay, it gets harder, right, as the list
It
goes
does.
on. But I was thinking integrated behavioral health, so maybe that is like e-consults, provider to provider type of support.
Perfect. Provider to provider specifically. Great. Marie? Oh, you're on mute.
Problem. Focusing on the family side of it, I think families that might be a little bit boutique, but families whose children are being transported and they are not in the rig with the child, they're not transporting with the child, the opportunity to give history and to the base is beforehand. So some pre-hospital history taking and from families. So pre-hospital family focused consultation with where the child's going to end up. It's a little bit kind of fancy, but I think that's a super helpful thing to for families to be able to give that history and give their perspective before the child arrives.
Perfect. Okay, so it's almost like a pre-screening or a history. Okay, great. Thanks. Who's next? Michelle.
So I think that kind of piggybacking off of the triage and crisis intervention, I think there's a lot of crisis in the family situation or questions in the family situation that come up that you can use telehealth to say, all right, this one is something that we want to get to the closest emergency department, or this is one that we want to get up to the children's hospital, and this is one that we want to be able to get back into primary care tomorrow, and closing that loop with primary care, specialty care, family. But I think that the emergency providers have a unique lens on this because we're used to seeing that full spectrum of like really sick and you need to go to the intensive care unit, and you were worried and sent in because somebody thought you needed to go to the intensive care unit, but you're okay to go home. So I think it's kind of trying to wrap a number of these things together, but I think there's a need for interconnectedness in the communication and bringing the system together around the family and child.
So coordination of providers, is that the right way to say that, or?
And I think like having the expert in emergencies helping understand whether or not this kid really needs to leave their house to come in or make that big trip across state or maybe across the ocean, depending on where you are, and then closing the loop back to the providers who are going to catch that kid after their initial crisis is settled out.
Okay, perfect. So does that capture it? Coordination, provider type, facility type? Yeah, care coordination across the system. Okay. And Jim, what else do you have to? Oh, he's on managing multiple meetings at once. Michael.
Yeah, along the care coordination route, looking at the direct-to-patient care, especially when it comes to behavioral with children, that can be done from the ED in itself, but also coordinating with whatever EMS unit that's in play there too. So it still comes back to care coordination. The other thought I had, which is continuation, is if there's ACOs involved, the wellness checks that can be done through audio services. So it's just check periodically as you go along.
Perfect.
Mike, are you talking about paramedicine essentially?
It can be the tele involvement in paramedicine, but also from the ED itself, because with the flexibilities that are in play, you could actually do it from the home can become an origination site. And so you can do it there, but you can also do it from like a critical access hospital that's local.
Thank you.
Along those lines.
Okay. Okay, great. And John, I don't know if you can kind of scroll up so everyone can see all of the items as we go, but what else is there to add? Maybe we can just spend a couple more minutes. So going back to you, Rachel, Rachel Abbey first, I guess. Is there
yeah, and I don't know if this is there, but is there a place for like referral services, like being able to refer people elsewhere? And I don't know if that's already on the list. I can't see the whole thing, sorry.
Okay, so we can add that referral service. I mean, there's consultation, but that's different, I think, from referral of where to send people. Great. And Rachel Alter, anything else to add?
Yeah, I think a lot of this could be considered community paramedicine, but I don't want to lose that concept and the potential of finding current programs that might be out there doing doing unique services that we'd want to learn from. I'm not sure if it belongs here or in another area, but I just didn't want to lose that thought.
So as a parking lot, I'm sorry, you're talking about things like coordination of, health insurance programs and things like that are sometimes part of that, and the wellness checks for issues and things.
Well, more of like maybe community paramedicine programs that are already in play that have some sort of mental health or children with special health care focus.
Okay. Okay. Did you capture that, John?
Yep.
Yeah. Okay. Perfect. And then Sabra, any last items, and then maybe we can move over to some of the regulatory pieces.
I would say school connections. I think that once there are children attending them in person, I think an ability for a school nurse or even not a school nurse to be able to say, is this rash a problem? Would be kind of an incredible resource and reassurance, as well as for more actual emergent situations, like getting that how to handle this asthma attack in real time while we're waiting for the ambulance, for just those sorts of things that I think could really bring everybody a lot of joy in a weird way.
Okay, perfect. Are there any major items that we left out here that anybody wants to shout out?
This may be too far afield, but for those of us that work in really high quaternary healthcare systems, coordination of complex care. We don't call it palliative care so much, and we do, but we don't. So children with incredibly complex care, the triangulation between the parent, the emergency department, and the complex care specialist physician, and that may go under like consultation, but I find that we could avoid the ED visits, which families would wish very hard to avoid with a kid that has a special vehicle to transport and a ventilator, et cetera. Complex care coordination would be a tremendous way to manage their emergent problems. They might be able to stay home because them coming into the ED has different goals than a kid who's having their first time status epilepticus and isn't already in a complex care situation. But I think if we think about children with special health care needs, not to deny them the opportunity to come to the ED if they need to do it, but to give them the opportunity to not come and have a triangulation of their complex care, the ED and the home environment, possibly even their visiting nurse.
Okay, perfect. And I saw, Michelle, you kind of added to that in the chat box. So if there are other items that you have that are burning questions, then please just maybe add them into the chat box, and we'll go ahead and move on to regulatory pieces just because of the sake of time. So I think, Sabra, you were the last. So Mike, I welcome back after your Ethan call, no problem at all. We are jumping into some regulatory requirements or changes that might be in place, licensing, credentialing, that might be available to support providers. So are there items that you can think of that you think should be part of that list? What are some changes that you've noticed from your end? Sorry, and that's Mike Gonzalez. Maybe he's still on mute.
Yeah. Hey, sorry. No, just finished up. Sorry, was the question for me? I'm so sorry.
Oh, sorry. I thought you had already finished, so maybe I should have.
No, it's okay.
So we're just moving into the regulatory requirements, licensing and credentialing. So do you have any thoughts of items that have helped to support this or foster this? Any changes?
Oh gosh, many thoughts on this. So I'll start with one. So I think it speaks to sort of the reimbursement strategies because they're related. When we started Ethan, there was really no framework for anything like this. And so there was no regulatory language from our state medical board or EMS about sort of doing, having a framework for physician involvement in the field, believe it or not. So community paramedicine as it existed with a sort of a mid-level, I know there's terms different, and I'm not trying to be derogatory about it, but there's having a provider out in the field, that was sort of well built, and there was a process and regulation around that. But having the ability to consult a physician via telehealth remotely, real time from the field just didn't exist. And so when we went out and kind of said, and so that's changed, and largely to the work many of you have done. And so, but I think there's still a lot of confusion, a lot of concern about whether, as many of you knew pre-COVID, there was a lot of concern about whether you could do an appropriate encounter around telehealth. So I think sort of maybe in a box, I think is sort of, it always boils down to sort of CMS, right? CMS language related to the use of actual telehealth for a variety of these kinds of encounters. And getting that language in place will be critical to the other part on the reimbursement strategy, because without one, you won't have the other.
And are you saying that specifically to EMS or across the board?
I think across the board,
yeah.
Because I mean, I can't imagine that it's that different. I know that I extensively researched a lot of the other outpatient sort of environments for telehealth as well when we started, and there really wasn't a lot. And I know that has changed, but I think there's still, even now, I mean, I have regular calls with CMS around what we're trying to do and how we do it, and there's still a lot of confusion, as well as there's really not good language to help work to make this framework applicable across, different states, as well as different entities that might be interested in using telehealth. So,
okay, perfect, thanks. Christina, what are your thoughts?
Okay, so I think tied to some of the services we identified there, the originating site reimbursement, which has just been that, that has to continue on if we want to continue on to have reimbursement when service is provided at the patient's location or patient's home.
Originating site reimbursement. Okay, perfect. Who is next? Sorry, Marie. I'm trying to keep track of the list. Did we lose her? Oh, there she is.
Oh.
Yes.
Were we on me? I got kicked off for a minute.
Oh, I thought so. I thought you maybe dropped off for a second. Yeah.
No, it was an internet issue. I missed the last 30 to 45 seconds.
No worries.
Oh, cross-border licensure is regionalization, and cross-border licensure is a big problem if you're delivering especially specialty care or disaster care, or trying to organize a situation, and you cannot deliver care across border due to different states' licensure, and you don't have like MOUs, et cetera. This is sometimes not known to the providers. They're asked to provide that care, and then they find out they're practicing medicine without a license. Now, you would think that emergency orders, et cetera, would allow for that, but emergency orders are different in different states, and there's not necessarily blanket immunity or blanket ability to deliver that care. So it's really important to understand the region, the state, the national licensure issue.
Okay, perfect. Thank you. Michelle.
Illinois, prior to emergency orders, had requirements for who was able to be a telepresenter, and so the care needed to be delivered within the context of a medical site. And so direct to home care was not available. So this telepresenter regulation would be my contribution. I'm going to keep it short this time.
Telepresenter regulation. Okay, perfect.
Sorry, can you repeat that? I had some feedback on my end.
I'll type it.
Okay, thanks, Michelle. And then Jim, what have you encountered in terms of?
I think everyone's going to be covering it. It's always about the money. If I don't want to offend Christina, but like I agree with the originating site reimbursement. So, but I think that reimbursement, so an allowable originating site to be reimbursed, that's a piece of it, but it's also even reimbursement beyond whether or not the home or school is an allowable originating site. So, and that's related to parity in payment. So, a more broad umbrella of reimbursement. And then the other thing, I'm just again thinking about this. Mike, I'm sure has a lot of expertise or an opinion on this, but it had scope of practice. And it has to do with the telepresenter as well. But if a first responder or home health nurse or whatever is going to be kind of helping to deliver this care, what's allowable in terms of the scope of practice, right? California does, at least the California Medical Association does everything it can to not allow the broadening scope of practice of other providers that are trying to use telehealth to get services to underserved populations, and that's fought tooth and nail by the physicians.
Okay, so do we have it captured here? Just
I would just say so allowable site. I would say scope of practice. And again, Mike, I'd want to hear what he has to say about that, given his expertise in it.
No, I think that's a great way of putting it. I think it's not only a scope of practice as it applies to the traditional community paramedicine models, but also the idea of doing outreach from a variety of centers direct to the home that could be not only nurse practitioners, but mental health professionals and all these different other entities that he's absolutely right. I mean, most of the time, the natural tendency is to try and the regulations are in place to try and prevent that creep. And, everybody probably has opinions about that, but if we're looking at trying to broadening care, especially out to places that are rural and don't have access to anything, then there should be maybe some exceptions inside of those rules that can be used. So,
right, or pharmacists with Narcan and all of these things, right? It doesn't have to always. I would get shot by the California Medical Association, but it's not. They always want the doctor,
always the physician,
type of a thing. But if we're going to really be able to do this, it can't be a doctor all of the time, or they can have some supervisory role, but allowing other people to provide stuff.
So can we add to that scope of practice diverse provider?
Yep. And then again, so
Yeah.
Yes, and then just I would say parity in payment as well as another line. I know that you have allowing originating site, but it's also just ensuring parity in payment. That if it's done over telemedicine, that it's paid the same as if it were done in person.
Okay, perfect. And then, and parity, Parity, right? Parity. Yes, thanks, Michelle. Okay, perfect. And then, Michael, what else do you have to add?
A couple things. On the licensure reportability, you have to understand that there are compacts that do exist that allow for PAs to do it across state lines, allow MPs, allow docs. So it depends on, a lot of those are related to state legislatures passing it and becoming a part of it and things becoming enacted. And we actually support programs specifically for that. And where that licensure reportability exists is that area is still growing. So it's something to be considered, especially in delivering emergency services. The other thing, right now we're in time of COVID flexibilities when it comes to telehealth. A lot of these things that weren't there prior to February, prior to January, are going to be extended. Every time the PHE gets extended, those things stay in place, but there's a lot of active legislation specifically to address keeping certain modalities of telehealth delivery, which will make it easier for some of the services to be delivered. I think it's one of those things that is evolving, right? And that is what we're talking about now won't be valid early next year.
Okay.
To a degree. And that's just something to be aware of, just the bills that are out there right now.
So we should probably add that. So rapid changes in regulatory requirements and transformation of that medical legal space. Is that right?
Yeah. Well, and it's understanding that CMS has changed some of the regs, what they could do without legislation. So it's understanding where that fits in, where ET3 fits in. So it's just, there are some things to look at.
Okay. So we only have about 18 more minutes. I want to try to get to technology requirements. So let's just run just a couple more through this because I don't think we've gotten to everyone. So Rachel, Abby, do you have anything you'd like to add to the regulatory piece?
I think probably training requirements, and then also that there may be also some technical requirements in legislation as well, particularly around privacy and security.
Perfect. And Rachel Alter?
I'm going to have to get used to this to Rachel thing.
I know.
Two things. One, as it relates to kind of scope of practice and compacts, there is an EMS compact that I'm not sure how many states are signed on to yet, but that does address that cross-border practice of medicine issue, which could be helpful in this scenario. And the other thing I just wanted to point out from the National EMS assessment we did earlier this year, that there's only 18 states that have are licensing community paramedicine agencies. So that's not very many, but a lot of this might have to do with community paramedicine. So it's just good to know.
Okay, so it's not just licensure compacts, but also broadening community paramedicine requirements or regulations. Is that right?
Mm-hmm. Yeah. And some states do have community paramedics that aren't licensed. So the national assessment numbers might be a little wonky just because even that there might not be legislation, but there still might be community paramedicine people running around.
Okay, perfect. And then Sabra, we're going to finish up with you. I think you're the last one to go on this.
Okay, I'm going to say, since I feel like I have the right audience for saying this, but is anything that CMS and HRSA can do to encourage / force parity with Medicare rules and regs to the states for managing Medicaid around this. So, if Medicare is allowing XYZ, really strongly encourage the states to do the same with Medicaid.
Great. Okay. So just for the sake of time, moving on to technology requirements. Mike, you're at the top of the list again, so we'll go ahead and start with you and go down the list.
Yeah, I don't really, so the options for doing telehealth have expanded immensely, even in the last 5 years. And I think they took another generational leap forward with COVID. But fundamentally, because we've been approached hundreds of times by other agencies who are asking if we could provide Ethan to their agency, municipality, whatever. And all of the limitations that we sort of talked about have been brought up as reasons why we couldn't do it. But the technology side is an interesting aspect in that the vast majority of places, everybody has a personal cell phone, but very few EMS agencies and on the receiving side have, particularly, let me focus on that first before I lose my train of thought. The EMS agencies have a device that is provided to them, but doesn't often have the connectivity or camera video technology necessary to do telehealth. So you get very quickly down this rabbit hole of, well, then I'm going to recommend people use their personal devices. And as soon as legal, most of the time, legal or anybody from risk gets word of that, they say like, oh, hold on, you can't do that. There's all sorts of HIPAA, even though most even commercially available telehealth platforms are now encrypted, but don't always meet the various regulatory requirements. So the thing that I would say, even though I know there's been a lot of work on that, and there's high trust, there's obviously HIPAA, the biggest hurdle I see is sort of a universal way to set a universal standard outside of those things. And if this exists, please, that's on me. But I feel like there's a lot of, every time we have this discussion with a different entity that we're talking about, they always throw HIPAA out there, which is sort of the most basic, least restrictive. But then once you start getting the IT people or involved, they start throwing high trust out there, which is, I feel like, way too far above what is required. So I sort of feel like in technology, even though this is a little bit going back to regulatory, yeah, I totally agree, Sarah. That's right in the comment. I think that there's the technology is widely available. It's just not always packaged in a way that I think is accessible to a lot of entities. So let me think about that a little bit more. But that's kind of my thoughts around some of the technology problems that we faced. But I'm not sure I voiced that in the best way. So let me think about it, and I'll put it in the comments if I come up with it. I know we're short on time.
Okay, sounds good. Thanks, Mike. Christina?
Sorry, I didn't realize I was up next. Yeah, so I can see where Mike's thinking, because I'm the same. There's different platforms. There's when he talked about no unified standard, it's all over the place there. I'm thinking broadband, access to broadband. But one thing that may not come up, so I'm going to say it, is the language translation services is a challenge that we're seeing.
Great. That's helpful. Thanks. Marie? You're on mute.
Sorry. I think the ability to manage the translation or the transmission of images, which can be done with certain types of technology, such as ultrasound, small handhelds, needs to absolutely be explored, because I think we've learned that in COVID especially, that the use of just plain x-ray or even advanced imaging, plain x-ray was not useful. People had to get CAT scans. That's not as applicable to children, but ultrasound became very important. And I think learning to use this modality in a nimble way, in a handheld way, and not in a massive $20,000 machine way will be important for this project.
Great. Okay. Thanks, Marie. Michelle, any other thoughts on technology?
I think that if there are models where there's a direct to consumer component, the accessibility for families, I think anybody who's learning right now knows that home bandwidth is a scarce resource. And then everybody has a cell phone, but not everybody has minutes on a cell phone. And so I think that there are some access issues there to consider.
Okay, great. Thanks. Jim? Still on? Oh, maybe he dropped off and he might have had to. Okay. Let's go to Michael. Is he still on?
Yeah, reflecting the same thing. Broadband, which is being written down, but also understanding that there are programs out there like Lifeline from the FCC, which provides phones, and that, you know, they give them out for emergency reasons. So those are free phones that are available with minutes for those that don't have it in general. So that's something that's being pushed. But pretty much everyone's hit everything else.
Okay, great. Rachel, Abby, anything else to add?
I would probably bring in like interoperability to make sure that whatever system, they can go across different networks. It can be used across different systems so that, you know, it's better access and so forth for folks.
Okay, great. Rachel Alter?
Yeah, my main thought was that rural backwoods scenario where you've got a drive time of 3 hours and no cell phone signal. That can't be solved here unless somebody has a direct connection to Elon Musk to get that satellite up in the sky. But I put in the chat box too that in that national EMS assessment that only 13 states indicated that they knew of agencies with video transmission capabilities. And of those, the Northern Mariana Islands, I think, identified they had 100%, but they've got one agency. And the other 12 indicated that only 10% of the agencies potentially have that ability.
Sure, that's thanks to Christina and Dwayne.
Yeah.
Okay, and then Sabra, and then we'll move on to the next thing after Sabra speaks.
I'm going to expand on the interoperability piece a little bit to be inclusive of the HIEs, the states are putting together, and payment systems to try to promote parity if it were easier.
Great.
To do.
Okay, perfect.
The HIEs especially, I just think would be, seems natural.
Yeah, and I know, I can't remember who mentioned it earlier. It might have been Rachel Abby about electronic health record integration, but that kind of falls within that, not just across the continuum, but also just integration into that overall. So thanks. So if you have other comments, again, put them in the chat box because we're short on time. So just trying to move through that. So moving over to how do we train providers to be able to provide telehealth services? And I think this is one of the challenges that we've seen is that many providers don't know where to begin, don't know how to do this. Are there programs out there, or what are the thoughts that you all have relative to provider training? And I guess, Mike, we're starting with you again. I'm sorry, we're on this regular cycle. I guess we're just short on time.
Yeah, no, that's okay. I think that we've done it. I have personally trained just about every medic that we do Ethan with, and I know this is a super. In order to comply with most of the existing state requirements around doing this, and as well as a lot of the regulation around reimbursement, it literally required us to do that. So again, sort of developing a framework for universal that we mentioned earlier would help with this, because I think that if there was some sort of not to add another sort of card that we all need to carry, but I feel like there's space for having something that says like, yes, you know, I've done this, I've been trained in it, and I don't need to, because there's a lot of discomfort around it initially for some providers, right? And so but my only experience, and this was a challenge, and I list it only for that reason, is that it really required a lot of individual hands-on training partly because when we built Ethan, it didn't exist and there was a lot of hesitancy around using it. But I think that it clearly, many of you are doing this already. And I really have learned more than anything around both this sort of group and a couple of others around how to universalize this training. So my only comment, I guess, in terms of what the framework should look like is that I think it would be most useful to try and develop some sort of either a certification or some sort of process that you could extend out, not so much by a badge organization that says, yes, you can do this, but more of a train the trainer model to say, you have an expert within each organization, and I've kind of de facto become that. And then sort of say, yes, like once that person certifies, and you can kind of do that. And maybe that's wishful thinking, but it is something that requires a dedicated training, mostly because you have a lot of, no matter what the organization is, I found you have a level of detractors who will be against telehealth even today, right? That just don't think it's possible, who don't think it works. And so having this sort of training, I think will help to sell that. And sorry, I went on too long again.
No worries, you're good. Thank you. All right, good. So Christina.
I have two things I wanted to say. One, for general, work with your telehealth resource centers. They do a lot of support in training at all various levels. So telehealth resource centers. But the other one, going more specific to this group, I don't know if it exists, but EMSC kind of telehealth best practice toolkit guidelines or something for the providers. So if it's quick and rapid, or if it's just what are some of the best practices that come up through this collaboration to document that and promote it.
Great. Okay. That's helpful. Thanks. And that's part of the purpose of this, hopefully, is to come up with some best practices. But yeah. Okay. Marie.
Yes. In terms of provider training, this might sound a little bit how should I say, commercial or selfish, but utilize all of these people that want to sell us things. Create a compendium of companies that are willing to provide either free training without getting in bed with them, without causing conflicts, without getting into trouble, or appearing to endorse. There are many, many provider trainings that can be done by a little bit of industry confluence or shared resources. And I know that's tricky, and I know that gets difficult with a not-for-profit situation because they expect you to buy their product, but those resources are out there, and people that have expertise in this know where they are and how to get those trainings without committing to a purchase of their resources, such as a peripheral product or iPads or something like that.
Perfect. Okay. Thanks. That's great. Michelle.
I think another thing to consider in this context is the unique aspects of care for kids and the evaluation of kids remotely who have medical complexity, and including that in training.
Great. Helpful. Okay. And Jim? Oh, Jim dropped off. Michael?
First, thanks for the plug earlier for the TRCs. Definitely what we're funding them for. So that's a big thing. The other thing is we also have 2 centers of excellence that have done school-based work specifically. And so they've done publications around those. So looking at those findings and also trying to, part of what they're trying to do is create technical assistance resources for workforce to a degree. So there are workforce aspects in what they're doing. The other thing to think about is that there's also been some telehealth research centers that we fund that have done some findings based on the school-based program. Also, something just came out on teleemergency. So there's a number of papers that are popping out through our research gateway. So just know that there's a research base developing on this, at least from a real point of view.
Perfect. Okay. Fantastic. Thanks. Rachel, Abby?
Yeah, so I'm kind of thinking outside the box in regards to providers, but I think along with training the direct care providers, I think it's also training like the IT staff on how to make wise decisions around, you know, telemedicine or telehealth products to buy, things like that. I think building up their capacity as well is important, and their knowledge.
Perfect. So training IT staff. And I'm sorry, you said what products to buy. So direction on products.
Like developers and like, you know, kind of products and requirements to look for, things like that. Yeah.
Perfect. Rachel Alter.
We have 5 seconds.
Promotion of the AAP children with special health care needs form that should be released soon.
We have just less than a minute left. Sabra, did you get all your comments into the chat box, or is there anything else that you would like to add?
I'm good.
You're good. Okay.
Yes.
Any final statements or burning pieces that we missed related to this or others? And Michelle, I see your ECHO model for training. So thanks for that. Any other burning pieces? Anything we missed elsewhere? Okay. All right, thanks you guys. I know this was quick, but we got through a lot of really great information, and what we'll be working to do is compile this so that during our next breakout session in November, you'll see kind of what you all have helped pull together, and we'll be able to. Okay. Yay, it looks like everyone made it back. This is good.
We had no choice. We got caught off mid-session.
Not that you mind, right? I'm joking. Thank you. Hopefully that was a good session for everyone. And I know we just have a few minutes left. So John, if you want to go to the next slide, and we'll turn it back to you with just some wrap up pieces. So one of the last things that we really wanted to do is just get your feedback. This is, you know, obviously our first real main session where we've been able to get together in breakout groups for this advisory council. So what we are going to do here in just a couple of minutes is launch an evaluation live. We thought that this was the best way that we can get your honest feedback. Before we close up, we didn't want to send it to you as something in follow-up. So you'll see that pop up on your screen. So please give us your feedback over the next couple minutes. We will be sharing the results. So nobody will be named, it's all anonymous, but we want to see what we can work on and try to be better about this as we move forward. The other piece that we want to mention before we close up is that our next meeting is on November 10th. This is a Tuesday rather than a Wednesday. Remember that November 11th was Veterans Day. We heard from many of our members that that was not an ideal day, of course, as a federal holiday. So we'll be pushing that to the Tuesday beforehand. And we're super excited to have Sabra Ankner, if I'm saying your name right, Sabra, I apologize, Christina Boothby and Beth Doretsky from Family Voices, all giving us some brief overviews of the work that they're doing to initiate telehealth programs, and all of them have received funding through the CARES Act to their relative organizations or specific organizations. So really looking forward to hearing a little bit more about that, and we'll reaching out to others for additional information. So Louis, do you want to go ahead and post the evaluation so we can go?
Hey, Kate, can I just want to remind our group, we took an option at the beginning to do a deeper dive into a couple of areas and then opted to follow up offline. So for our group, we'll send out those highlighted boxes that need completion offline, and we'll hope to get those back in 10 days.
Great. Okay. Okay. So everyone should have received the evaluation. So please go ahead and let us know.
I think we're pretty close to everyone submitting their feedback. We are 24.
And the one thing I will say is that if you do have comments, please go ahead and share those in the chat box. We know that the survey doesn't really allow you to comment directly into it. So if there are comments that you'd like us to share or see, please go ahead and share those in the chat box, either broadly or individually, whatever you feel more comfortable with. We appreciate that. So, okay. So many thanks again to everyone's time today. Hopefully the breakout sessions were more or less useful. We're about to find out and we'll see how to move forward. So, okay, so in terms of the overview, so again, this was really mostly the orientation session that we shared in September. Sounds like the majority felt that was very effective. So great. If there are specific questions or comments that you all have about that or the role, please let us know if there's any outstanding issues. And that session was recorded and you should be able to access that as well on the website. The next question on how effective was the breakout session? It sounds like people enjoyed that, generally speaking. So that's great to hear. And hopefully we'll continue to move forward. How did folks like the round robin? Can you give maybe a thumbs up, thumbs down in terms of your reaction to that? The round robin, okay? Thumbs up, okay, okay, great. The next piece is where the deliverables clearly defined. So 54% said yes, 42% moderately. So we need to provide maybe a little bit more information around what we're looking for with the environmental scan. We know this was the first session, so we'll provide a little bit more information on that. Technology-wise, sounds like it worked today, which is always a shock to our amusement, so that's great. And then regarding materials, so looks like we can maybe do a little bit better job with materials ahead of time. So we'll work on getting some agendas to you guys ahead of time and some pre-work. And I know we'll have some internal discussions around that and how we can make this better moving forward. So thanks for that feedback. And again, please do share some comments in the chat box if you haven't already done so. And we will gladly receive those so that we can make adjustments as needed moving forward. So the meeting in November, again, it'll be a relatively similar format, but by that time we'll be able to compile much of the work that you all did today during the breakout sessions. We'll put that into a little bit more of a usable format. Hopefully we can get some of that to you all ahead of time so that you can even review it before we jump into our breakout sessions, because I think that'll be useful, especially based on the feedback that I'm seeing here for materials and ahead of time. So I think that's all we have today. Charles or Sarah, anything else that you all would like to say before we close out today?
No, we just really excited that the group was so engaged and really excited about the next steps of this work.
Great. Okay. Wonderful. We've actually finished a few minutes early, so thank you all so much for your time, and we'll see you on November 10th. Thanks. All right. It's just us.
Yep.
How did it go? That was a lot of information. How was it, Charles?
Yeah, we decided only because of the imbalance in the expertise in our group, I felt that the round robin was going to put a heavy burden on people who didn't have the same, like Tom was at one extreme of that. And so the potential to alienate people that are at the other end was pretty great. I didn't know that Sue Duffy wasn't going to be on the call because she also has the same sort of content knowledge.
Mhm.
We did a much deeper dive, and it accomplished what we were hoping to accomplish because we were able to elicit conversations from everyone. We tracked comments and who made the comments, and you can see a good balance in all the comments, but it was clear that one comment would elicit another. There was a lot of commonality between the group.